What are likely to be the implications of the IPRX TDF2 and partnered studies for the future of PrEP?
I think the first thing we have to say about the oral pre-exposure prophylaxis or PrEP trials is that there is a clear gender difference. The outcomes in men have been consistent. We have 3 trials, and all 3 have shown efficacy for prevention of HIV acquisition in men. 2 in heterosexual men, and then IPREX in gay, bisexual, and other men who have sex with men, and transgender persons. But for women, the situation is much more ambivalent. We have a mixed picture, and we also have a mixed picture with topical microbicides, the vaginal microbicides with 1% tenofovir gel. So I think we have to disaggregate that, and there obviously is an important research agenda there. And for many people, and particularly for governments and national AIDS programs and for some of the donors, until there's more clarity for the situation in women, it's a challenge to move forward with the implementation of PrEP as a prevention tool for many players and in many countries. Now that said, the data on men are quite clear and compelling and consistent. And when you have 3 consistent clinical trials that all show the same positive outcome for prevention, that is, by virtually all standards of modern clinical trials, public health science, a real indication to go forward. I would argue, and I think many would argue, that because we have such a severe epidemic underway in men who have sex with men in particular, now 61% of new infections in the United States, despite being only about 1.5% of the adult population, that for men who have sex with men, the shift toward implementing any preventive tool with efficacy is a very different risk-benefit calculus. And I think we really need to be exploring how to improve uptake, how to improve provider comfort and interest in using this intervention, and figuring out who the right people are who would benefit from it, and who we might be able to help reduce their risk of acquisition. There's particularly compelling data from the US, internationally, developing countries, that young men who have sex with men, particularly the 18 to 24-year-olds, are the folks who are at the most risk for acquisition and who may benefit the most from this intervention. But that's a challenge, that's a paradox for PrEP, because at least in IPREX, there was recent data presented at CROI that suggests that adherence, which is the Achilles heel of this approach as a prevention tool, is lower in younger persons. So we really are facing a challenge around implementation. Nevertheless, I think there are so few interventions out there with evidence for efficacy in the reduction of HIV acquisition for men generally, but also for men who have sex with men, that we really need to do our utmost to try and understand how best to use this tool and to get it out there and start helping men protect themselves from HIV infection. Short of implementing PrEP, we have basically ARV treatment for HIV-positive men, which may have implications for uninfected men, but actually hasn't been proven in men who have sex with men. And then we have the condom, and it's very clear that we can only get condom use up so high, even with the best behavioral interventions. And the next cohorts of young men who have sex with men are not using condoms at any higher rates than their seniors. And the HIV acquisition risk for these guys is just unacceptably high. So I think we really have a difficult, compelling, critical agenda ahead of us in figuring out how best to use this intervention now that we know it works, target it to the right people, get clinicians and providers to use it, and build that community interest for demand. This is only going to work if people want it, ask for it, and use it.